Welcome to The Explainer. Today, we're unpacking the complete evidence landscape of Ebola virus disease. And I'll tell you right now, we aren't just looking at the virology here. We're looking at a profound stress test. It's a test of human speed, medical care, and really the ultimate resilience of our entire global health system.
So let's dive right into this. If you've watched the news at any point over the past decade, you've probably seen a lot of the sensationalized myths surrounding Ebola. But today, I want to ask you to look past that whole Hollywood framing. What does it actually take to survive this disease? And what does it take to actually contain it? Well, the answers definitely aren't based on luck. They're deeply rooted in complex, interconnected data that dictates exactly how we fight back.
To answer those questions, we're turning to an absolutely unprecedented volume of evidence. I mean, look at this number. Over 4.7 million. That is the total number of participant and sample observations synthesized in the massive SAIMSARA scoping review. It actually maps out 2,251 original studies just to give us this complete, high-definition evidence landscape of the disease. To make sense of all of this, here's our roadmap for today. We'll cover the ultimate health stress test, acute outcomes and clinical risk, breakthroughs in vaccines and therapeutics, viral persistence and survivor sequelae, public health and outbreak control, and we'll wrap up with the complete evidence landscape.
Okay, Section 1, Acute Outcomes and Clinical Risk, because survival is certainly not random.
Let's start with how microscopic biology translates directly into a patient's prognosis. When someone is tested using molecular diagnostics, doctors look at something called the cycle threshold, or the CT value. Think of it kind of like a search party. If the diagnostic machine has to run a ton of cycles, meaning a high CT value, just to find the iris, it means the patient has a very low viral load. And multiple clinical cohorts prove that this low viremia vastly improves a patient's odds. Viral burden really is the central prognostic marker here. Now, this brings us to another absolutely critical non-random factor, which is age. You can clearly see a stark contrast in mortality here, creating this harsh U-shaped curve of vulnerability. While the case fatality rate for adults sits at about 66.2%, the extremes are just devastating. Children under 5 face a massive 82.9% mortality rate, and for the elderly over 60, it's 80.6%. The physiological toll on the very young and the aging is incredibly severe.
But here's where we get to push back against the myth that infection is just an automatic death sentence. Basic, immediate, supportive care, specifically things like aggressive IV fluid resuscitation and electrolyte correction, actually reduces short-term mortality risk by 74%. That's a huge deal. Ebola causes massive fluid loss, so stepping in early with basic organ support is a proven fundamental lifesaver. When it comes down to it, speed of care dictates survival.
Moving right along to Section 2, breakthroughs in vaccines and therapeutics. This is all about shifting the paradigm of care.
For a really long time, the experimental drug ZMapp was the standard go-to, but it carried a nearly 50% mortality rate. Then, everything changed with the PALM trial. This trial tested new monoclonal antibodies, specifically MAb114 and REGN-EB3. These incredible therapies go in and directly neutralize the virus, bringing mortality down to the 33 to 35% range. It's solid proof that we can engineer targeted, effective defenses against this pathogen.
And then we have the rVSV-ZEBOV vaccine. Honestly, its success is a monumental milestone in public health. In clinical ring vaccination trials, it showed 100% efficacy. No, really, 100%. And its real-world effectiveness holds super strong at 84%. But maybe the most fascinating piece of data here is what happens during breakthrough infections. If someone who is vaccinated still manages to catch the disease, their mortality risk plummets to 25%. The vaccine is actively reducing disease severity and even preventing things like acute kidney injury. It's just a game changer.
All right, Section 3, viral persistence and survivor sequelae. Let's look at the long tail of Ebola.
You know, surviving the initial disease is, unfortunately, really only the first stage of the battle. A staggering 86.7% of survivors wind up dealing with post-Ebola syndrome. And we aren't just talking about a little mild fatigue here. This involves severe long-term musculoskeletal pain, neurocognitive memory loss, and serious eye complications like uveitis. The physiological damage echoes long after a patient actually tests negative in their blood.
And the reason for all of this brings us to a frankly remarkable, if not terrifying, feature of the virus. Ebola is incredibly adept at hiding. It physically retreats into what we call immune-privileged sites. These are parts of the body where the immune system is naturally suppressed, so it doesn't cause damaging inflammation. We're talking about the central nervous system, the aqueous humor of the eyes, the testes, and even breast milk. Because the immune system isn't aggressively policing these specific areas, the virus can just hang out and persist there for months, or sometimes even years after recovery.
So, the absolutely crucial point here is that this persistence creates a rare but highly critical phenomenon known as recrudescence, or a relapse. We have documented cases where this hidden virus reemerges. Sometimes it leads to delayed sexual transmission or even fatal meningoencephalitis, and it can literally spark entirely new transmission chains months later. This just highlights the absolute, vital need for sustained, respectful, and highly comprehensive survivor monitoring and care. We literally cannot afford to abandon patients the moment they're discharged.
Which brings us to Section 4, Public Health and Outbreak Control. Because the best science in the world still requires a resilient system. Stopping an epidemic relies on a very delicate four-part chain. First up, rapid molecular diagnostics, like the expert EBOV assay, which can turn results around in hours instead of days. Second is meticulous contact tracing. Third is safe and dignified burials, because traditional funeral practices have historically been major transmission multipliers. And fourth, the absolute linchpin of the whole operation, community trust. Honestly, if communities fear the treatment centers or feel they need to hide their symptoms, the first three steps completely fall apart. It's a house of cards.
And when that system does fall apart, the virus ends up claiming victims it never even touches. During major outbreaks, the sheer overwhelming burden of Ebola essentially collapses the broader healthcare system. Maternity wards shut down, routine vaccinations just halts. And as this quote notes, just a 50% drop in normal healthcare access leads to thousands of collateral deaths from diseases we normally keep in check, like HIV, TB, and malaria.
To really put that into perspective, take a look at this number: 10,900. That's the estimated number of additional malaria-attributable deaths that occurred across West Africa strictly because the health system was disrupted by Ebola. It completely solidifies a critical public health reality. An outbreak's true death toll extends way, way beyond the virus itself. The collateral damage caused by a collapsing health system is just immense.
Let's pull this all together in Section 5, the complete evidence landscape, connecting the micro to the macro. If you take away just one single thing from this explainer today, please let it be this core thesis. Ebola virology, clinical care, and sociology form a single, deeply interconnected ecosystem. Fighting this disease is a multifaceted stress test. It requires us to attack the molecular pathogen with advanced vaccines and therapeutics, for sure. But we have to simultaneously address the societal structures and the health system vulnerabilities that give the virus the room to spread in the first place.
Which leaves us with a pretty provocative question to consider. We now have over 4.7 million data points. We know exactly what to do. But are our global health systems genuinely prepared to apply this vast evidence map before the next spillover event actually occurs? The data is clearly there, the science is mapped out. But readiness? Readiness is an active, ongoing choice we have to make.
If you're a clinician, a researcher, a public health professional, or honestly just someone fascinated by the complex science of outbreak response, I highly encourage you to read the full SAIMSARA evidence map. It's an incredible resource that lays out the complete referenced Ebola virus disease landscape. Thank you so much for joining me on this explainer today. Keep asking those big questions, and I'll catch you next time as we dive into more fascinating science.